actually, we're using the Tebentafusp in clinical routine already for quite a while, so we got some experience with it in real world. And I think what the 3-year data clearly shows is that there still is a benefit, and the absolute difference was about 10% compared to investigator's choice, which was mainly the immune checkpoint blocker pembrolizumab. So you can see after 3 years, still the overall survival benefit for patients treated with Tebentafusp. And actually, which is very nice, there were some real-world data from the early access program presented by Paul Nathan at last ESMO, and these real-world data showed the exact median overall survival like in the clinical trial. So it is 21 months for the Tebentafusp. So it shows that the clinical trial data translate very well into clinics, into routine clinics, and and that the Tebentafusp is doing what the trial shows. Yeah, when you use the Tebentafusp, of course, this is a completely new kind of immunotherapies that we are using. So you need to gain some experience and be trained by experienced centers when you use it, because actually there are 2 side effects that can occur with the Tebentafusp, and one that is very rarely serious is the cytokine release syndrome. So of course you need to gain some experience how to handle it and how to prevent it as well. So for example, with IV infusions with some electrolytes to help the blood pressure is something you can do, of course. Otherwise, you treat symptomatically for the fever, but you have to be careful and have to have an intensive care unit in backup for the rare events of severe cytokine release syndrome. So I think this is something new. So it's very, very good to be trained by someone who used it in a clinical trial or has now used it for a while in clinical routine. And otherwise, the question concerning the multidisciplinary setting, I think this shows when you use the treatment, when the treatment is tolerated very well, which happens in most of the patients, you don't really need anybody else for therapy, but you need a backup in case you have a really severe cytokine release syndrome. So you need the intensive care unit as a backup. But for me, the multidisciplinary team is much more important far earlier, so before the detection of the metastasis, to make sure that the patient, after you discovered the primary tumor in the eye, gets a good follow-up. Because what we learn with the Tebentafusp is the less tumor burden you have, the more likely the patient is to really benefit from it. So if the patient comes because has pain from a swollen liver, that's just too late for the Tebentafusp. So I think there you really need teamwork to make sure the patient is coming to the follow-ups and the metastatic disease is discovered early. Yeah, with Tebentafusp therapy, we had to learn something new. Usually in oncology, what we use is radiological staging. And then we see if the tumors become smaller or if they get bigger. So if we have a response or if the patient shows progressive disease. With Tebentafusp, it seems that the Tebentafusp induces responses not so frequently. So we have it in about 11% of patients. We see a response to the treatment. And otherwise, you have stabilization or even progressive disease. So about half of the patients have progressive disease as best response. And there's a bit the problem, because when you just look at the patients with the progressive disease as best response, you still see an overall survival benefit compared to investigator's choice. So it seems to be that maybe patients with Tebentafusp just have a slower progression and therefore benefit for overall survival. And so if you do follow up the patient under Tebentafusp, you can't just stay with the radiologic exams. You have to look for the tumor marker. So for the tumor burden, LDH at the moment, we would love to have ctDNA to see if there might be a response in ctDNA, even though you see a progressive disease in the staging, but we don't have it in clinical routine yet. We hope we will have it soon. But at the moment, it's the radiologic report, the general condition of the patient, and the tumor marker in the peripheral blood. And with all together, we try to decide how long beyond progression we treat the patient.